Okay, so hello everybody. I am Dr. Khalid Zitouna. I am delighted to welcome you to this session of Orthopedics Monday. We are going to talk about worst cases in the proximal femoral fracture. First of all, I want to thank the moderators and especially our guests, Dr. Aissam Al-Maghribi, Deputy Chairman of Arab Board Training Committee, and Dr. Ahmed Sawiris, Arab Board Scientific Council Secretary. Thanks also for Dr. Bouatour Karim, Sotcot Vice Chairman, and Dr. Bou Abdallah Mohammed, Coordinator of the Tunisian Group of Hip and Knee. I would also like to thank my friends, the 7 speakers, who will present 7 interesting clinical cases. Dr. Jassim Saadana from Fatouma Bourguiba Hospital of Monastir, Dr. Lasad Hassini from Sahlul Hospital, Sous, Dr. Rasim Gidara from Sfax Habib Bourguiba Hospital, Dr. Hisham Abid from La Marsa, Dr. Amin Salman from Trauma Center of Tunis, Ben Arous, Dr. Wajdi Arfa, Pediatric Orthopedics Department of Qassab Institute, Tunis, and Dr. Mahdi Ben Ayed from La Rabta Hospital from Tunis. So we will start with the first folder, and I would kindly ask you to turn off your mic, c'est déjà fait, during the presentation. After each presentation, you can ask your questions or make your comments in English via the Zoom chat. Pour ceux qui ont un problème avec l'anglais, vous pouvez utiliser Google Translate et copier-coller sur le chat. Donc, Dr. Hisham Abid.
Okay, so let's start with the first case.
So, Dr. Sawiris asked for to say something to welcome people. Dr. Ahmed.
تمام أشكركم للفرصة دي. أنا آسف if I just interrupted the meeting, لكن it's the first time to have a combined meeting of the Tunisian Society and the Arab Board of Orthopedics. So I would like to take this chance and thank everyone who organized and who are attending this meeting. It comes at a time when the collaboration between the Arab Board and the Tunisian side have been enhanced. Today in the Facebook, the Arab Board has already posted that the Tunisian side have received accreditation for the Tunisian universities for training. Congratulations for both, for us as Arab Board and for you as the Tunisian side. So I would like to recommend that, and hopefully there will be more and more collaboration. Thank you very much.
Thank you. Thank you for your gentle words.
Great.
Hi, Hisham.
So let's start with the first case. Our patient is a 90-year-old woman. She's obese and she fell at home. And here is the X-ray, the AP view, and we can see a subtrochanteric fracture. The first pitfall in this case is that there is no lateral views and no CT scan. So she had a long proximal femoral nail, and here you can see the postoperative X-ray. And the second pitfall of our case is that they used only fluoroscopy and there was no postoperative lateral view. If we consider the fracture, it is an unstable fracture. It's a A33 type AO fracture. And as for the nail, the fixation was done in varus. The medial cortical support was negative. The tip apex distance is not respected, and there was a lateral wall fracture. So we get back to our patient, and this is the X-ray at 3 months postoperatively. We can see a cutout of the nail and a nail migration. At 4 months postoperatively, there is a sliding of the helicoidal blade and an up migration of the nail. At 5 months postoperatively, the patient was in pain. She couldn't walk. So a CT scan was done. And if we look at the CT scan, we can see an associated femoral neck fracture. And if we look at the CT scan again, we can see that the screw was out of the nail. Our patient had a total hip arthroplasty at 6 months, and she could recover walking. So, some papers studied the role of preoperative CT scan in the assessment of the trochanteric fracture and planning. And the association of intertrochanteric fracture and femoral neck fracture is rare, and only 5 cases were published. And here I think that we should establish indications for an initial CT scan for these fractures. This paper published in GBGS by the American Academy of Orthopedic Surgeons gives us some tips to improve results. Tip 1 is to use the tip to apex distance. Tip 2, no lateral wall, no hip screw. Tip 3, know the unstable intertrochanteric fracture patterns and nail them. And tip 4, avoid virus angulation of the proximal fragment. Use the relationship between the tip of the trochanter and the center of the femoral head. The tip apex distance was developed by Baumgartner. A TAD superior to 25 millimeters significantly increases the risk of screw cutout. There is a close correlation between TAD and lax screw cutout risk. Also, central or inferior positioning on AP view and central positioning on lateral view is recommended. Reduction quality is also an important factor. Finally, in this paper published in 1996, 3 screws over 150 were out of the nail. The recommendation is not to trust the ancillary, to check that the ancillary is well fixed, and to do lateral fluoroscopy views. And thank you.
Okay.
خالد زيتونة. خالد.
They don't have the mic.
So, what do you think about osteosynthesis? A lot of problem, isn't?
Can I make a comment? I mean, this is a perfect case. I now know why Ramzi was saying they are nightmare cases. They are the worst cases. It could be due to the fracture itself. It could be due to the management. I can say that this time it is due to the management because they did not obtain adequate views. And I would recommend, as the author has already presented, to do this without fluoroscopy, because otherwise you wouldn't have missed that the screw or the helical blade is outside the nail. The salvage, I like the fact that they have kept the trochanters, which are partially intact, which means that at least the attachments of the muscles, the abductors, and only the replacement has been done with a conventional short stem, avoiding the need for any calcar replacing or long stem. So the salvage has been done well. The initial procedure should have been done in a more careful way.
No question at this
There is
time.
a problem with the mics.
With Mike.
The mics, yes.
Yes.
Dr. Isam would like to have his mic unmuted. So
Yes,
you're unmuted, Isam, now.
yes, yes.
And Dr. Bozidi also.
For me, can I speak, please?
We can hear you.
Yes, yes. For me, this is unstable fracture. Of course, there is also, neck fracture. But if this only a Subtrochanteric fracture, this is unstable fracture with no lateral wall and on the intramedullary device only, because when we don't have lateral wall, we have to add a plate or something like cerclage to add stability, what they called augmentation. So the augmentation is better in this type of fracture, not only to put intramedullary nail, but also to put a small plate or cerclage to increase the strength of the fixation.
Yes, absolutely.
And what do you think about the CT scan before to assess?
ربنا مات قلبه. اللي تعب اعمل بالعشاء.
Please mute your mic. Tartassis, please, les modérateurs uniquement et Khaled Zitouna
Et le présentateur.
et les présentateurs. Mettez les autres micros en mode mute, please. What do you Issam about CT scan to assess complex fractures when we can miss the diagnosis of associated femoral neck fracture like this case?
I would say that for one thing, CT is not mandatory in every case, but you could substitute that with a good AP view in internal rotation and traction. So if you can get that, that will give you a better idea of the fracture configuration. Otherwise, you should not be, as the presenter was saying, I mean, you should not go for fixation with only one view, and you cannot have adequate viewing. If you're in doubt, any doubt, then a CT scan would make your life easier. I'm not quite sure whether the femoral neck fracture was present initially or occurred during fixation, because we don't have any views during that.
Yeah.
The initial X-ray suggests that there might be a femoral neck fracture, but even with these trochanteric fractures, you can miss associated fractures if you do, or at least more than one view.
Pour
As
les...
Dr. Imad said, okay, excuse me.
Yes.
Non, 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 Catharsis, Dr. Bouatour demande à ce que le micro soit ouvert. Dr. Marbi?
Yes, as Dr. Imad said,
Yes.
it is intertrochanteric fracture. It is, as you said, it is a rare case, 5 cases only in the literature. So we don't have to go for CT for all intertrochanteric fracture.
Okay.
We have a comment in
the chat.
Yes, I think the age of the patient with osteoporosis can do arthroplasty directly. We can, Hisham, you can show us the first
Yes, of
X-ray. Total hip directly.
Until the X-ray comes up, I would like to comment on several factors. funny enough, I came from a meeting in Egypt for the General Organization for Teaching Hospitals and Institutes, where the whole meeting was on obesity.
Hello?
And part of it, effect of obesity on the bone and on the fixation. And this patient has several risk factors. She's 90, so she's a geriatric population. She is obese, which carries with it the diabetes, hyperlipidemia, hypertension, all the other risk factors, and these do not get a very good result. So I trust that they have already probably worked very well before surgery, but we have to be very careful. Regarding osteoporosis, you can see that the SING index, which is the decussation between, or the presence of the primary and secondary compression and tension trabeculae, is not bad. The fact that it has cut out is probably related to the position of the helical blades, which it has already been pointed out by the presenter, Hisham, which is the tip apex distance and the position of the screw.
Yes.
And the blade was already outside the nail. And would you, Dr. Abu Abdullah and Dr. Abu Attur, and I would like to ask you a question. Did you seen already one case like that when gamma nail or something like that, or PFN, the nail or the lag screw outside the nail? Did you see a case like that?
I didn't see before, but I think it's possible because of the use many times of the ancillary.
Ancillary. Yes.
It can occur, and this emphasizes the necessity to check the lateral view on the X-ray. It's necessary.
So
in literature,
yes,
in literature, this is a rare complication. Case reports. This complication is reported when we use an intramedullary hip screw with the flexible targeting device, and when the canal is not large, it's a narrow femoral canal. And this complication comes especially when we adjust the guide wire in intervention by using the carbon fiber. It's not rigid. It's not rigid and allow the lag screw to be outside the nail. The prevention, we must be awareness to have a good quality of intraoperative fluoroscopy, especially in the lateral X-ray view, to prevent this complication.
Okay.
There is so many factors that occurs in this case, and many technical mistakes, I think. So to answer the question about the prosthesis in the first time, I don't think so. I think you have to avoid this mistake and not to perform a prosthesis in this case.
Yes.
Can I make a comment? Because of the obesity of this patient, there is and the type of the fracture, there is a problem from the beginning. One is this is probably an a pertrochanteric, not an intertrochanteric. I know this is a nomenclature problem, but an intertrochanteric is the one, or the pertrochanteric, sorry, is the one which goes from the greater to the lesser trochanter. This one I would call either a reverse obliquity or a pertrochanteric, because the greater trochanter is part of the proximal fragment, or you can say it's a subtrochanteric. These fractures, number one, are difficult to reduce. So sometimes you would have to use a joystick. A joystick, either a stout K-wire or a Steinman pin, or you do the reduction open. And this is why the surgeon ended up in varus position. The other thing is because of the obesity, remember, you would want to have the leg in adduction in order to get the entry point of the nail at the tip of the trochanter or slightly medial to that. And with this big obesity, the problem is you cannot get to the entry point. Even if you can get to the entry point, you'll start your reaming with the fracture in varus. So number one is because you have to recognize the obesity. You might need to do an open reduction, or you might need to get your entry point slightly medial, and you need to have the fracture in the reduced position before you fix it. The nail is not a reduction tool, so you cannot use the nail for reduction.
Okay, thanks everybody. Thanks, Hisham. We are late, so we move on the next case, a pediatric case. Dr. Wajdi Arva. Ready, Wajdi?
Yes. So I will share my screen.
This is a pediatric case.
Okay, does anyone show? Is my screen visible for you?
Yes, go on.
Yes.
Okay, thank you. So hello everyone. We present this case of a 30-year-old boy with no previous medical history who was the victim of a traffic accident. He was a cyclist hit by a car, causing trauma to his right hip. The X-ray, as you can see, shows a Delbert type 2 fracture of the neck of the right femur. So the patient underwent urgent surgery. The fracture was reduced using external maneuvers on an orthopedic table, followed by fixation with two distal threaded cannulated screws. Here is the postoperative X-rays. So no weight bearing on the right lower limb was recommended. At 3 months post-operatively, the child resumed weight bearing on his operated limb, but since then he had been complaining of progressively worsening mechanical pain. The physical examination revealed right lameness and painfully limited mobility of the right hip. His 6-month postoperative X-ray showed a non-union of the cervical fracture as well as the failure of the fixation and the breakage of the superior screw. The coxavara and the trosa displacement were also noted. Here are the CT images showing the non-union site, the displacement of the head, and the failure of the fixation. No signs of infection were found. Given this situation, our therapeutic approach was first to remove the screws, then to perform a Powell's intertrochanteric valgus osteotomy fixed with a dynamic hip screw at an angle of 140 degrees. Here is the intraoperative fluoroscopy. The hip of the broken screw was left in place as we didn't want to remove it, which could further impair the already poor blood supply of the head. And here are the immediate postoperative X-rays image. And here is the X-ray at 8 months postoperatively. The non-union appears healed and the femoral head appears non-necrotic. Clinically, the boy had no pain and full hip mobility. There was a 1 centimeter shortening of the right lower limb explained by the shortened femoral neck. And at last follow-up at 2 years and a half postoperatively, the X-ray findings showed a healed non-union that appears to have vitality preserved with a good position of the implant. So this review of the literature published in 2020 in the Journal of Bone and Joint Surgery demonstrated that the children ranks third among complications after osteonecrosis and epiphysiodesis. Its prevalence is around 10.8% with the maximum up to 14%. There are several risk factors Delpit type 2 with the vertical orientation of the fracture line, pathological nature of the fracture, orthopedic treatment, operating time for more than 24 hours, and non-compliance with the technical requirements, which are as follows. So anatomic reduction should ideally be achieved by external maneuver, if not by open surgery. If screws are to be used, at least 2 must be inserted. Their trajectory must be parallel, and the threaded part must be located entirely above the fracture to ensure a good compression. Those conditions was not obtained in our case and may explain the occurrence of non-union. If the child is under 8 years of age, spica cast must be added systematically. If the child is over 8 years of age, we should opt for an implant with a side plate such as the dynamic hip screw. At last, the stability of the fixation is more important than the preservation of the cervical growth plate, so don't hesitate to extend it with screws if stability requires it. For the treatment of this non-union, the Powell's valgus osteotomy is the gold standard as it transforms vertical forces which are healing into compression forces which are beneficial. And the occurrence of epiphyseal osteonecrosis is not a contraindication. Thank you.
Thank you.
Oui, Khalid.
We remember everybody to keep micro closed, please.
Pour Khalid Zitouna.
Oui.
Micro pour Khalid Zitouna, s'il te plaît, Slim Kartassis, s'il te plaît. Pour les modérateurs et Khalid Zitouna, il faut laisser le micro ouvert tout le temps. Et fermez les autres micros, s'il vous plaît.
Maybe we can begin the discussion. Maybe some technique.
So I have a question for the moderators.
Yeah.
Would you have for this case? Would you have chosen another option? We have a question in the chat. 2 screws are not enough for this fracture.
Can I give my opinion?
Yes.
As you seen in this case, in this fracture Delpit 2 displaced fracture of children, first of all, there is criticism of this fixation. First of all, the screws are short. The screws are not parallel. And there is missing of a third screw to have more stability. And if you observe the contralateral hip, I think this fixation is practiced in varus fixation. All these factors explain the failure of this procedure. What we recommend? Here, there is closed reduction. If closed reduction can be carried out in many situations, but if reduction is not anatomic, surgeon can change plan and proceed to open reduction, or if open reduction and internal fixation. In this case, we must use 3 screws. Screw must be placed perhaps 5 millimeters from the subchondral bone and should be inserted across the physeal growth plate in parallel position to provide enough stability. And as shown in this case, if there is non-union, intertrochanteric osteotomy can be a safe method to ensure healing. I think we must pay attention. No anatomic reduction or if. No anatomic reduction or if. Because there is risk of non-union and osteonecrosis.
Isam, in your practice, you have to. No, you don't have pediatric practice in your fracture?
Yes, we have, but I think, as the presenter said, the fracture line is vertical, and in this type of fracture, maybe from the beginning, you know, the shearing force is important. There is no compressive force here. So from the beginning, maybe it is better to use the DHS and not the screws, you know. I think, and in pediatric, we don't put three screws. It is, you know, in adult, yes, but in pediatric, 2 screws. But as he said also, we can go through the physis and not, you know, concern about the physis, because the threads must cross the fracture side. And I think from the beginning, maybe it is better to do fixation with DHS and not with screw, because this fracture is grossly unstable, because the fracture is vertical and shearing force is enormous. In French, it is.
Yes.
Okay.
High shearing force.
Ahmed, you have an opinion on that?
remove the
ميكرو s'il te plaît ميكرو دو عماد ساويرس يا سليم بالله. عماد ساويرس، محمد بو عبد الله، خالد زيتونة، كريم بو عتور، خلي لهم الميكرو محلول.
Please, all moderators, you have all mic are open, so do not touch your mics, please, please.
Okay.
حلوا الميكرو عماد.
Right, now I can speak. I've been unmuted. Thank you. I like the fact that most of the cases, or at least the 2 cases which have been presented now, are well thought. The lessons from the cases are already presented by the presenter or the speaker. So this is very well. I congratulate the Tunisian Association for that. I would say anatomical reduction is one of the important things, and I'm surprised that nobody has mentioned open reduction, because unless you can get a perfect anatomical reduction, you cannot be sure that these fractures will heal, and you should not be hesitating to do an open reduction. And open reduction in the children is not very difficult. You can still do that and use joysticks, or you can open the joint and see it, either in a separate incision or from the same incision if you use a Watson-Jones approach. The other comment, I thank the speaker for having these 2 lines. It's not the fact that the screws are not parallel, but usually the most important screw is the inferior one, and the inferior one has to hug the calcar. So the screw is still a little bit further up from the lesser trochanter, so it wouldn't cause a subtrochanteric fracture. It wouldn't be a worry. So you can still have an entry point for the screw, which is a little bit inferior, therefore getting an angle to get support on the calcar itself. This would have been a better fixation. The other thing, at least to me, I guess these are the 7.3 cannulated screws, which are used in adults. If this is true, the 7.3 screws have got a 16 and a 32 millimeters thread. So you could have used a screw which has got 16 millimeters thread rather than the 32 millimeters. 13 years is almost an adult. So you can at least, my first choice would be a DHS and 1 screw above. but my second choice would be 2 or 3 screws. 2 screws, as Sam has mentioned already, but with a shorter thread. So the trajectory of this inferior screw plus the depth of the threads are the 2 points that I can add.
Okay.
Okay, it's we may move for the next case. Dr. Lasad Hassini.
Je vais essayer de partager. Voilà, c'est bon, là, ça.
C'est Hicham Abid qui va partager.
Ah, ok, super.
Dr. Hisham, we can see the presentation if you want to start.
Dr.
Is he
Hassini.
unmuted?
Dr. Lasad Hassini, le micro de
Oui.
Dr. Hassini, c'est bon, hein?
Vous m'entendez?
C'est
Yeah.
bon.
Ok, merci. So, good evening, everybody. This is a 67-year-old female patient with no prior medical history, admitted in to our department for a left hip trauma following a slip. The initial radiological assessment shows a left Subtrochanteric fracture that appears stable on the available imaging. Next. This is another view of the fracture. The patient underwent internal fixation with a dynamic hip screw, and here is the follow-up X-ray showing a satisfactory reduction and an acceptable position of the fixation hardware. 2 months later, this is the follow-up X-ray. But at 7 months, the follow-up X-ray reveals cutting all out of the cephalic screw. For this reason, the patient underwent total hip arthroplasty.
Maybe a technical problem?
Asad?
Il est sorti, il se reconnecte.
Maybe we can continue with the explanation with this paper. Can I, Dr. Zitouna?
Yeah, you can.
Yes.
I thank you. As shown in this paper, the risk factor for cut out after dynamic hip screw, three main factors were identified: male gender, non-anatomic reduction, and defective light screw positioning.
So
Next, please.
Je peux continuer?
Yes. Go.
So to decrease the risk of leg screw cut out, it is important to achieve a good fracture reduction, to place the leg screw in middle or inferior middle position, and to have an appropriate TAD less than 15 millimeters. In conclusion, you need to have a good fracture reduction and an appropriate TAD less than 15 millimeters. Thank you.
25.
Thanks.
Yeah,
Let's
it is
ask.
20. It is 25, not
25.
25.
Yeah, we've all recognized that.
So,
I start with the question.
yeah.
Yes. So, in your opinion, why the fracture which is well fixed move to 2 months, and what are the indications of the dynamic hip screw for the proximal fracture?
I think if we review the X-ray, this fracture
Hisham,
never healed. So
we can show the
yeah, if
the
we can
case
see the X-ray at 7 months.
X-ray at 7 months.
Yeah, maybe it is a non-union. So when the patient had a full bearing, it's necessary to have a cutout. So I think it's not a problem of non-union and maybe a necrosis of the head. What do you think about?
We can show the first X-ray after the operative. No. The first the control. Voilà. Do you have a comment on this?
Can I comment, please?
Yeah.
Yes.
I think this is not stable fracture, as you said, because we have a fracture of the greater trochanter. If you notice, there is a fracture of the greater trochanter, and maybe we have to add, trochanteric stabilizing plate if we want to continue with the DHS or a PFN. It is not really a stable one.
So it was
Do you,
better.
do you think it's an indication of gamma nail? One of those questions.
Yeah, well, I don't know, but I see there is a fracture of the greater trochanter. What do you think about that? There is no fracture?
We must fix the greater trochanter.
Yes, when you have fracture of the greater trochanter,
yes,
maybe,
yes.
But yeah, we have.
Yes, we have.
No?
Yes.
Yeah, if we have a fracture of the greater trochanter, this is not really a stable one. Okay, it is unstable, and the unstable fracture, the DHS is not, an indication. Or if you want to go with the DHS, you have to add a plate. We call it TSP, trochanteric stabilizing plate, on the top of the DHS. And the TAD is, I think the TAD is okay. It's respected, I think.
Can I comment?
Yes.
Right. In my mind, I usually separate between two entities. One is the stability of the fracture, two is the quality of the bone. So regarding this, I agree that it might not be as stable as we thought initially because of this greater trochanter fracture. The fracture line starts lateral to the tip of the trochanter, which means that the lateral wall might not be as thick as possible. Sam has already commented that in these cases, you might need to add a TSP because you want to prevent lateral wall collapse or prevent fracture of the lateral wall. But this didn't happen in this case. So it's not the problem of the lateral wall thickness, which can cause a fracture intraoperative and medialization and loss of stability. The problem is in the position of the screw itself, the DHS screw, as well as the quality of the bone. And this is what causes the cutout. You can prevent the cutout by having a valgus reduction. I think this reduction is in reasonable degree of valgus. I might not have put it in any more valgus. Perhaps a little bit more might be all right. But at least it is a little bit superior in the femoral head. So superior and anterior, actually, because if you look at the lateral view, the trochanter is posterior. So you can make out that this is posterior and anterior is on the other side. So this screw is slightly superior and anterior. Coupled with the bad quality of the bone, this has already resulted in the cutout. So the thin lateral wall, TSP or PFM, yes, or gamma nail. Poor quality of the bone, you have to make out your mind first. One is insert the screw very deep. We usually have it at least less than or almost 5 millimeters from the subchondral bone. This is the only place where the screw will hold. And try either center or center inferior, as the speaker has already mentioned. I'll stop here because I have a comment on the hip replacement later on. So I keep the discussion running in the direction of the quality of the bone and the initial fixation. And when we come back to the replacement, I can comment on that.
Can I comment also? Can I have a...
Yes.
Because we have to also to check that this case is a secondary cutout. So 7 months after the fixation. So it's not really the same management or the same problems of the immediately cut out related to the quality of bone and the quality of the reduction and fixation. But this cutout happened 7 months after the fixation. So there's also a lack of healing. Non-union is also a problem that occurs secondary, and maybe that's why this cutout happened later, 7 months after the fixation. So there is several factors, and we can discuss all the factors, but I agree with you, Dr. Isam. This is an unstable fracture. Lesser trochanteric is fractured, so posteromedial stability. There is 2 factors of instability and quality of bone. So it's unstable fracture, osteoporosis. The fixation was critical, but as you know, when we see this in our morning, the daily meeting after fixation, we'll see, okay, that's okay. It's a fixation. We cannot, it's acceptable. So after that, 2 months, the fixation is stable, but after 7 months, there is a cutout. So mad, I think.
Totally agree.
When we have early cutout and later
That's
cutout.
true, but if the screw was a little bit more inferior, more deep in the head into subchondral bone, it would have probably survived. I have cases like that where the screw was still holding very well in the head while the fracture has not healed, and it failed somewhere else, not by cutout. It failed by varus deformity and other mechanisms.
We can see other this fracture seems as a basicervical fracture. Basicervical fracture was considered as a significant risk factor for screw cut out, and we must use improved nail design such as a rotation controlled leg screw, because the DHS can now prevent the instability in rotation. We can add a screw, superior screw, or use other design such as the U-clip or the twin interlocking derotation and compression screw. That means the intramedullary nail with 2 screws, 1 leg screw and anti-rotation screw to prevent instability in rotation.
Okay, thanks, everybody. We move on for the case. Dr. Guidara. The fourth case.
You see the screen?
Yes, full screen.
Good evening, everyone. It's always a pleasure to share clinical cases in Orthopedic Mondays with friends, colleagues, and teachers. So our case today is about a 52-year-old patient without medical history who had a domestic accident. He fell at home. He came to the emergency for left hip trauma with pain and lower limb deformity. X-rays shows a basicervical femoral neck fracture associated with a fracture of the greater trochanter. A CT scan was performed with 3D views for better analysis of the fixation was decided. We performed a dynamic hip screw with tension band wiring of the greater trochanter. That was the fluoroscopic imaging before and after surgery. And this is the fluoroscopic lateral view of the performed fixation. 1 month after surgery, no pain felt, weight bearing was prohibited. 2 months after surgery, we noticed the same appearance of X-rays. The weight-bearing band has been extended for another month. 3 months later, X-rays showed a secondary displacement with no signs of femoral lead fusion. Weight-bearing was very painful. This is the current X-ray 10 months after surgery, with femoral head non-union and cutting out of the cervical screw. The patient is not yet operated. He is scheduled for fixation device removal and a total hip arthroplasty. In literature, the combination of femoral neck and greater trochanter fractures is extremely rare. Only few case reports were published. The use of LCP proximal femoral hook plates seems to be a good option to fix these complex fractures. And thank you.
Thanks, Rassam, for this case. So, would you have chosen another option? We can show the first X-ray, Rassam.
Yes, of course.
Here we have a CT scan also.
Yes.
We have the CT scan. So another option for the moderators or for everybody.
Khalid.
Yes.
I think if we see in this case, first of all, there is a non-anatomic reduction. The reduction is inverse.
We can see the reduction, Rassam.
Reduction inverse. If we compare this to the contralateral hip, it's inverse. First of all, there is a short screw and tip apex distance superior than 20 millimeters. As I said in the last case, there is absence of anti-rotational system. DHS, there is instability in rotation. All these factors can explain the failure of this procedure. And in case of transcervical displaced fracture, if external reduction is not to proceed by using ORIF technique. As said by Dr. Imad, anterolateral Watson-Jones, we can get a good reduction by anterior reduction. I think the proximal femoral anatomic plate, as they said, is an interesting alternative of this case. It allows to fix greater trochanter with multiple screw of the femoral neck to ensure fixation and anti-rotation of a fracture. Thanks.
And for the type of osteosynthesis, for type of fixation, do you have a comment?
Dr. Johnny Abdel Noor, which is name Jasim here in Kartasis, please, Salim, open for Jasim, because Dr. Johnny Abdel Noor have a lot of comments, and he asked me.
I'm sure he will have a lot of comments. Can I make a small comment?
يا اخي انا طالب اتكلم بس هطق.
Sorry.
هو ده جوني عبد النور.
He can rename himself.
Jasim. But
why using a camouflage name?
He using the
You can still rename yourself. You can still rename yourself. Can I make a small comment? Somebody has posted in the chat about the lateral wall thickness. Remember, lateral wall thickness is applicable if the lateral wall is intact and you're worried that it will fracture during fixation. But this lateral wall is not there anymore. So there is no lateral wall because of the fracture of the trochanter. As one of the moderators commented, it's a basicervical, it's a cervical fracture, it's cervical one, and this is the one reduction. This is the one that needs rotational stability. So there is no rotational stability. This fracture was doomed to fail from the beginning. Dr. Abu Abdullah has already mentioned that.
Exactly.
Yeah.
So I don't know which name, Johnny Abdel Noor.
Johnny Abdel Noor Jasim.
Raise your hand.
Jasim? Oh, you can raise your hand, Dr. Johnny.
Raise your hand, Johnny.
Jasim. Jasim, there is no Jasim on the list.
We can move, and he will comment at the end. I will call him.
Yes.
Right. If we are considering a hip replacement in this case, which I think is a reasonable option, of course you need to remove the metal, which might not be an easy operation, risk of infection, risk of dislocation. But one of the comments from the previous case is that the surgeon in the previous case had to use a long neck and has probably lengthened the hip itself. Oh, Johnny Abdel Noor is iPhone 131, is not Jasim. I can see him waving in the screen. Johnny, just keep your hand still in front of the camera, and it will make a gesture as raising hand.
You can speak. Okay. I found him. I find him.
هلا سامعيني؟
Yeah. Okay. Now. يا هلا نورت الميتنج.
يا هلا فيكم. بتعرفوا انه انا ما بقدر اسكت.
Sure.
انا ما بقدر any comments. First of all, for the fracture of the neck in this 30-year-old boy. Well, I just would like to stress one thing. The teaching at present is not to put 3 screws. At times we put 2. or one. Isam mentioned it, and I back him fully. Now, as far as intertrochanteric fractures, there are three aspects that we look at. We look at the medial aspect, the lesser trochanter, which gives us instability. We look at the lateral wall, and we look at the reversibility of the fracture, the reversing of the fracture. Now, let me tell you, in modern times, the dynamic hip screw has been nearly discontinued. It's obsolete in the States. Not many use it. Why? Because we like to use an intramedullary process. Why? Because we medialize the forces on a deficient medial wall, and therefore the chances for anything to pull out are much less. So this is the number one reason why I would use an intramedullary gamma nail on many of the cases that a dynamic hip screw was used. Another point, somebody mentioned something which is important. The screw in one of the fractures that migrated superiorly. The screw is put in a position that I, through my 50 years of experience, realize this. Whenever I don't put the screw towards the inferior aspect of the neck, in osteoporotic patients, the chances for it to migrate, and I think I might stress this point. So these are points you have to realize and follow in these cases.
Exactly.
Okay?
Thanks so much, Johnny. Yala, keep your mic open and don't stop talking now until the end.
Yala, I shut up.
Dr. Bouzidi, we move on the fifth
We move
case.
the next case, yes.
Okay.
You will see, Johnny.
Salman.
Yes.
Let's go, Salman.
That's okay for you?
Full screen, please.
Yes.
Yes. Okay.
Perfect. Hello, everyone. We're moving for the fifth case. It's about an 80-year-old woman who fell from own height and presents to the emergency room with this X-ray, which showed a complex proximal femoral fracture. So if you look closely to the X-ray, we can suspect some difficulties. It's an unstable fracture with a lesser trochanter avulsion, and we can see the lateral cortex tearing. If you want to classify it, according to the AO classification, it's a 31A33 fracture, which is a multifragmentary fracture with extension to the lateral wall. So the patient has undergone surgery of reduction and internal fixation with a long gamma nail and a lateral cortex cerclage in the nail. But as you can see in this postoperative X-ray, there was a big gap in the fracture site. 6 weeks after, the patient came back with these X-rays. As you can see here, there was an intra-articular migration of the screw. The cerclage has broken away, and there was no sign of bone healing. So the patient has been revised. Removal of the locking screw has been made. Setback of the cervical cephalic screw and nail dynamization. 2 months after that, as you backwards of the cervical cephalic screw. So the decision was to make removal of all the implants and logically to prepare the patient for the total hip arthroplasty, which has been made 1 month after. And we can see on the intraoperative images the path of the screw on this femoral head, and we've made cerclage on the lateral wall of the proximal femur on this total hip arthroplasty. 1 month after the total hip arthroplasty, the greater trochanter has gone away, but fortunately the patient had a good function. 4 months after that, the lateral cortex was still here. There was no bone lesions and still a good function. So, what was the problem for this patient? If we see the initial postoperative X-ray, we can see this big destruction on the site. Maybe there was an articular passage with the key wire before drilling, and maybe also there was an early weight bearing. And according to this paper, we have to know that elderly hip fracture patients are really unable to maintain postoperative weight bearing restrictions. So, how to prevent this such? There is a solution, which is a cement augmented anti-rotation nail, which can reduce cutout and the screw migration, but of course it has to be done on a well-reduced and fixed fracture. Thank you.
Thanks, Amin. So to start the discussion, I have a question. When do you allow weight bearing for trochanteric fracture? Immediately, 1 month, 6 weeks? For all moderators, I want an answer.
In this case or in general?
In general.
But it depends. Usually after a gamma nail, I think is after a few days. But in this case, maybe after 2 or 3 weeks. But when you look to the distraction, technical problems that in this case.
Can I make a comment? The idea of the operation in these elderly patients is to allow weight bearing immediately. And as the speaker has mentioned, they do not comply with partial weight bearing or weight bearing restrictions. So your fixation, your fixation has to be adequate to allow full weight bearing from the start. Otherwise, you go for another option. So the problem here is not the weight bearing. The problem is the fixation itself. I agree that the fracture was already unstable from the beginning. The errors we had is, yes, we don't have a lateral wall, so the fixation with a cephalomedullary fixation is the choice. The point of entry of this fixation was lateral to the tip of the trochanter, and this resulted in varus angulation. The reduction with all the trochanteric fractures, the unstable ones, are the reduction has to be dependent on the anteromedial cortex. This is the only intact part of the fracture which can support weight bearing together with the cephalomedullary nail. So in order to achieve that, number one, your point of entry for the nail, for the screw itself in the nail, will have to be posterior so that you keep the anterior cortex intact. Your point of entry of the nail itself will have to be slightly medial to the tip of the trochanter to maintain the valgus reduction, because a varus reduction will doom this fixation for failure. And once you get an adequate fixation, then you can allow weight bearing. The reason this patient was not allowed weight bearing is because of the technical error rather than the quality of the fracture itself.
Yes, Dr. Abdullah?
I agree with Dr. Imad. In this case, as we see, I won't use the term of personality of this fracture. It's unstable fracture, as you know, classified A33 in AO classification with osteoporosis. Here we see that the reduction respect the angle between neck and the shaft, but we see a lateral wall fracture which ideally require a plate to lateral wall to stabilize the lateral wall. Here there is a medial cortical support with negative effects, and there is distraction. All this factor allows cut out and migration. There is a point, I must add a point. There is no idea about the set screw, which ideally must be in static position to avoid varus displacement, as shown in biomechanic studies. The set screw, the superior, the set screw must be static, because if is dynamic, it will allow deformation in varus and the cut out. There is a final point. If the set screw is not fixed well, it can allow medial migration in the pelvis. Pay attention when you use the set screw. It must be well fixed in the lag screw to avoid medial migration. And if, I agree, we can recommend cement augmentation in this screw, but it's a good condition, necessary but non-sufficient condition. We must have anatomic reduction. Thanks.
We have a question in the chat. Dr. Yusuf Athman, is a preoperative CT scan helpful in such fractures?
Johnny,
Hey,
do you have a comment on that?
I have a comment. First of all, the fracture tells us what we are going to be faced with. First of all, we have the lesser trochanter, which is fractured. Second of all, we have over-distraction of the fracture site. And third of all, we have the nail put in varus, as Dr. Ahmed mentioned. And all three put together is going to lead to a failure. Now, you speak about weight bearing in these cases. Well, this patient is locked both distally and proximally. So all the load is going to come on the gap. And this is going to promote the hip from going into varus and from pulling out. So these are points that should be taken care of. Now, when we reduce these fractures, we should aim at the proper alignment that everybody has stressed. And especially if we want these patients to weight bear, weight bearing in itself is very important for healing. And this is the point I'd like to mention. I think the technique is what led this patient to have this complication. And that's it. And actually, I think that this is rather a subtrochanteric comminuted fracture. I don't know how many would classify this into an intertrochanteric, and others will classify it into a subtrochanteric fracture. Mm-hmm. I don't know. You see, these are points which one should consider. Okay? Pay attention to the lateral wall. Pay attention to the medial comminution. Pay attention to the obliquity, and pay attention to your reduction. All these put together will prevent you from having complications. I know we still do have problems. 4 factors should always be kept in our mind. And thank you.
Thanks, Johnny.
Thanks.
Thank you.
Any comment? Or we move with the next case?
I think, as Dr. Mohammed said, it is the important thing here is the good reduction. And they speak now about the over reduction. It's meaning that the peak of the proximal fragment is overlapping or riding on the medial cortex of the distal fragment. Here we see that you know, the peak is inside the cancellous bone. So there is no really contact between the cortex and the medial part. The subtrochanter is not important here, but we have to preserve this continuity of the medial wall.
Perfect.
And also,
Okay.
as Johnny said, I will add something that in this cases and other cases of unstable and complex fractures, classification, I think, is not very important. AO classification or other. But yes, really here we have to evaluate point by point, and each fracture is analyzed alone to check if it's a stable or unstable fracture and manage it as well as it. I think classification is not very important, Johnny.
I know, but I'm kind of wondering, is this a subtrochanteric or an intertrochanteric fracture?
Yeah, that's why I'm telling you.
The thing is, you would treat it equally well, irrespective of the classification. The important things, as we said, is the only point which is still intact is the anteromedial cortex. So as Assam was saying, a positive reduction is important. This is the only contact. Lateral wall is only important if it was intact from the beginning, and then you fracture it when you're reaming the triple reamer. If it's not there, by all means, you will have to go for a cephalomedullary nail. So this point is just a philosophy. So all of them will get a cephalomedullary nail, and that's it.
Ahmed, would you consider doing any other form of fixation in this case? I'm kind of wondering, would anybody consider
the same form of fixation,
exactly,
but in a better reduction?
I agree.
And maybe with 2 screws in the neck rather than the 1 screw. That's totally
agree. Is there any plate for a right-angled plate, compression plate, as we used to put in the past?
The reason the Americans use the PFN rather than the DHS is because they do not know how to use the DHS. They have forgotten how to do that. And this is exactly like the modern surgeons who can do a laparoscopic cholecystectomy, and once it converts into open, they cannot do it. So if the thing is, any other way of fixation, we as an older generation have been trained on the 95-degree fixation. I don't think the current generations know how to use the 95 fixation angle fixation, whether it is a PFN, a DCS, or a blade plate, or even the proximal femoral plate. So if you get them to use something they are not used to, they will cause catastrophes. So keep them with the PFN. They know how to use it, but just get them out of the trouble.
There is some question in the chat, Khalid, I think, no? How was inflammatory markers for this patient?
Was there any signs of suspected infection at the hip arthroplasty?
Doctor, no, it wasn't. No.
No.
We can see the X-ray.
No infection. No.
The X-ray of.
No sign of infection. No.
Okay.
Okay.
Next.
Do you hear me?
Yeah.
Yes. Okay. The next. Mahdi Ben Ayed. Mahdi.
Can you see my screen?
Yeah.
Yes.
So good evening, everybody.
No, it's not for full screen, Mahdi.
Okay.
Voilà.
Yeah.
So let's carry on with the 6th case. It's about a 60 years old male with diabetes who has a stroke in 2007 and has left hemiparesis. He had the left hip trauma in December 2020. The X-rays showed an unstable multifragmentary subtrochanteric fracture, A3.3 of AO classification, with displaced fracture of the lesser trochanter and extension to the femoral shaft. The surgery was performed 5 days after the trauma. An open reduction with intramedullary fixation by a long gamma nail was performed, associated to a cerclage wiring of the lesser trochanter and fixation of the lateral wall with a 4.5 compression screw. Unfortunately, we don't have the early postoperative X-rays. These are the 2-month follow-up X-rays. Weight bearing was allowed 3 months after the surgery. The patient returned after 4 months with hip pain, weight bearing difficulties, and no sign of infection. This is the X-ray performed at 4 months. It shows a fracture of the cervicocephalic screw, a fracture of the femoral neck, and the non-union of the subtrochanteric fracture with incarceration of the cerclage wire. This is the X-ray at the last follow-up at 4 years after the surgery. It shows a non-union of the femoral neck fracture and the vertical migration of the femoral shaft. The CT scan confirms the non-union of the femoral neck and the greater trochanter. If you look through the literature, the most recent paper identified 2 main parameters which predict the cutout risk after internal fixation of trochanteric fracture. First, the quality of reduction, and second, the optimal device positioning. This recent multiple variable analysis recommended the use of tip apex distance, calcar reference tip apex distance, and Chang reduction quality criteria to predict the risk of cutout. This other paper concluded that calcar reference tip apex distance is the key evaluation tool for predicting the cutout. Other cutout predictors have been identified, such as negative medial cortical support and a lateral fracture line, which can affect the intramedullary nail stability. Let's now look again to our intramedullary fixation. There is a lateral wall fracture poorly reduced, a negative medial cortical support, and a high TAD. Would it have been better if we did a closed reduction without using a cerclage wiring? We found 2 papers about the subjects. The first one compares the result of closed reduction and open reduction with the cerclage wiring. They found better outcomes in the cerclage group. The second one was a recent meta-analysis of comparative studies, which found that cerclage wiring was associated with lower time to bone fusion, lower prevalence of varus displacement, with a comparable complication rate. About the lateral wall fracture, there's 2 recent Chinese papers recommended the addition of a buttress plate to intramedullary nailing to increase the construct stiffness and reduce the stress in the implant and the femur. So, what would you have done differently? And thank you.
Thanks, Mahdi. For this fracture, what type of implant do you propose? A question for moderators or other people?
In the past, we used the long time blade plate, and it was successful. 130 blade plate, long plate, and it was successful. And now with using the nail, a lot of complication.
A long gamma nail.
Yeah. But there is many technical ask about the open reduction. I think it was a good idea, especially with the This screw is not enough, and the wire, the cow wire, is not a cerclage, I think.
And what about the fracture of cervical screw?
In my opinion, is a stress fracture because of the non-union.
May I ask
Yeah.
a question? First of all, how old is the patient? How did it happen, the fracture? Is he paralyzed, of what I understood, or what?
He has hemiparesis.
Hemiparesis. One
Yes.
should consider in these fractures, when you have such a complication, to think of what? Of a Charcot joint. This patient has a Charcot hip. And what has happened, no matter what you've used in this case, it's going to break. You have to think of it by taking a proper history from the patient. He has had a hemiplegia, and this could be the result leading to a Charcot joint. It's a typical Charcot joint. I'm sorry I mentioned this, but this is my opinion. I've seen cases
Johnny,
like
I
this.
beg.
What?
I beg to differ. I mean, the joint itself
I
was
don't
pristine.
care. It does
Even
happen.
with failure of fixation, the joint itself was maintained. I mean, if you get the X-rays with
I know, but it's the fracture that
the
does
screw
not heal.
broken.
We've seen many
No, it's not.
cases of
It's a mechanical
diabetics
problem.
in the ankle. I don't think it's a
Yeah.
mechanical problem. I think it's a condition secondary to the comorbid state of the patient. It's my
How do you
opinion.
describe this? Sure. How do you describe this joint space?
The joint space,
It's
look
a
at
spherical head,
when you speak
congruous
of,
inside
I know, but
an
Charcot joint
acetabulum.
has no relation to a joint space. It's related to fractures uniting or not uniting or forming. Now, at this stage, being that I would know that this is a complication that I was not going to be aware of because it occurs by surprise. It occurs, you're surprised. Now the enigma is what to do now. What to do now if this patient was walking. So there's nothing left but do a total joint and hope for the best because he's going to have heterotopic ossification. And for this reason, I'll send this patient to receive 700 rads or put him for 6 months on indomethacin when I do the surgery. Otherwise, he's going to run into the same problem. Okay?
Yeah.
Okay.
Can I make a comment on the initial fixation, please? I mean, if we had the initial X-ray, the preoperative X-ray, to me, the preoperative,
The
one
first
before
X-ray,
the nail
Preoperative.
was inserted, the first
Yes.
X-ray. Okay. To me, this is an eye-opener because I would have chosen the cephalomedullary nail as the surgeon have used. But in retrospect, I would say, no, this is not a very good option. Number one is the reverse obliquity would mean that the lateral wall was bound to be fractured. So when you enter with your proximal screw or the hip screw, you would fracture this lateral wall. You haven't got any medial support at all. And the circulation does not add any stability in such a comminuted fracture. The circulation will probably reduce a lesser trochanter, but here it wouldn't even reduce a lesser trochanter. You haven't got any medial cortex. So to me, this was inevitable. I would agree with Dr. Karim that we needed to go a little bit higher up, either a 95-degree angled fixation or the locked proximal femoral plates. And this can be even inserted in a MIPO technique. So you try and get the reduction by joysticks, you get the an incision at the proximal fragment, and then you slide the nail across, and you depend on the nail fixation itself, because we haven't got anything supporting on the medial side.
Dr. Ahmad, if you don't have any medial support, you will have, a bad result, because the medial cortex or the compression side is not in continuity. What do you think?
Yeah, but as you say, as you can see, the proximal fragment has been reduced in size by the fact that the lateral wall was broken. So instead of having a good lateral proximal fragment, now the proximal fragment is composed of the greater trochanter and the head and neck only. So the whole thing is toggling onto the hip screw. Or the other thing, as people has mentioned, is to have the screw a little bit inside. Inserted deeper.
I think this fracture must be reduced open, not closed, as you said.
It has been reduced open. The circulage wire was probably inserted open together with
open.
the screw of the lateral wall. This was an open reduction because of the screw inserted at the lateral wall and the circulage. The surgeon has definitely opened this one, but he failed to reduce it.
Yeah. So we have to think about this problem. If it is a Charcot disease, Charcot joint, we cannot indicate total hip replacement, and this is a problem also. Huh? And this condition remind us that all these fractures of proximal femoral fractures are not only a fracture, it's a disease, and this concerns all the general condition of the patient. And we have to remind all the attendees and all the surgeons that we have to take care about the general conditions of our patients before analyzing and choosing the fixation device and the reduction, classification. The patient and general condition of the patient is very important. And I have received a message now from Dr. Khalil Amri, who is a member of our society, and he is telling us that I cannot open my mic, but I want you to tell the attendees that we are talking about also the patient, not only the fracture. And Johnny Abdul reminds that. Thanks, Johnny.
You are most welcome. But think of what I told you. Look in the books. See, it's a way that we learn from each other. And that's the best policy. I am going to now go into and read about the Charcot joint and about the fracture that occurs. But I'll tell you, Inti Ramsey, you deal with these cases. Patients who have fractures and they have problems with the spine and they're hemiplegic and they're bedridden, they sustain certain types of trauma, they end up having heterotopic ossification. Now, we do know in patients at my time, not at your time, you're still young, we had many patients who had syphilis. And we used to see case after case. Don't ask me how many cases of total hip I did in patients who had, I discovered later on that they had Charcot joints. So you have to keep this in mind. I agree, whoever made this comment, I highly thank him for making the comment. Look at the comorbidities of the patient. Think of the patient beforehand. Patient is 92. Is he walking? That's the first these are points that we have to consider. You got the point? The anesthesiologist considers these for us, but they shouldn't. We should be the ones to search into them. And that's it, Ramsey. Thank you, Ramsey.
Okay, thanks. The last case, Dr. Jason Saadena. And after, if we have a few moments, we can show the case of Dr. Issam Al-Maghribi. If you are ready, we have 20 minutes. Jason, Dr. Saadena.
I don't see Dr. Saadena in the room.
He is ready.
Okay.
Jason? We have another name, Jason?
If not ready, maybe we can move to the next case, the case of
Dr. Issam.
Yes.
Dr. Issam, you are ready?
Yes.
Okay.
I'm here.
And share your screen.
Yes.
Hello, everybody. I'm here.
Oh, Dr. Khalid is here.
Dr. Jason?
Jassim, sorry.
Hello, everybody.
Okay, Dr. Jason.
Can you
Dr.
see,
Issam,
can you see my screen?
Dr. Jason.
Thank you,
Okay,
everybody.
can I proceed?
Oh, Dr. Jassim is here. He will probably present his case as well.
For few
It's for you, Dr. Issam.
Yalla, Jason.
Thank
Hi,
you,
Jason.
Thank you, Dr. Khan. I'm honored to present my work case for this orthopedic day. This is 52-year-old patient with no significant medical history.
Your slide there, Jason.
I changed.
It's the admin. It's the admin who is sharing the screen.
Yes,
so the admin
okay,
can
it's
move
okay.
the slides for him.
It's a 52-year-old patient who was involved in road traffic in 2023. The accident resulted in a staged left trauma with a diagnostic finding including displaced proximal fracture, fracture of two bone legs, malleolar fracture. The subtrochanteric fracture was initially treated with closed reduction and medium gamma. This fracture was classified 52C11 with the AU classification is an subtrochanteric fracture and lateral femoral fracture. The patient was discharged the second day post-operatively with only anterior-posterior view. The reduction was adequate in this anterior-posterior view. What about the lateral view? 4 months later, the fracture was now reducted with flexion of proximal fragment and non-aligned femoral arcs. The evolution was marked by the development of aseptic non-union and distal looped screw broken. The CT scan showed that the fracture is displaced and non-union 8 months post-operatively. The patient underwent reoperation in 2024 with dynamization of the nail, removal of the undesired bone fragment. The sequenced result as shown in the following X-ray for January 2025 and indicate the fracture is healing. can be treated with intramedullary nailing with closed reduction. But some of these fractures are only managed with open reduction and extramedullary support. The augmentation of intramedullary nailing with using the plate and cable contribute to the reduction of the lateral femoral weight, like in our case. And thank you.
Thanks, Jason, for this case. If you have comments or questions.
Subtrochanteric fracture equals open reduction. I would say so. I mean, you definitely need to open these fractures in order to control on them. Reduction before nailing. So open reduction, reduction before nail.
Yes, I fully agree with you, Ahmed. Without reduction, don't fix.
Exact.
You have to reduce, and open reduction is the only manner to do, because there is no other option. You cannot reduce.
You can see the deforming
fractures. You cannot reduce these fractures by closed. Yeah.
Exact. I think if we resume this case, the personality of this fracture, it's an unstable fracture with high displaced fracture, more than 100% displaced. There is extension of fracture to diaphyseal shaft, to the shaft. And when we see the postoperative X-ray, there is unreduced fracture. This fracture is not well reduced. And to reduce, as said Dr. Imad, it must require open reduction for this fracture. Stabilization by a strong circlage or a short plate. A short plate can reduce the fracture. The short nail, here there is a short nail. And as you've seen, the top tip apex distance is superior than 20 millimeters. And the lag screw is posterior in the lateral view. This factor give the evolution to non-union. I think excised the bony protrusion, it's not a good solution. It's a random attitude. We should proceed by revision, circlage to reduce the fracture, a long nail, and a bone graft. It's more safe than this procedure.
May I make a small comment, Dr. Ramsey?
Yeah, yes.
May I? Look it. I'm going to make this comment for the residents more than the rest. I agree fully. Thank you.
We have comments on the presence. What about shortening in the lower limb?
Shortening?
Yes. For Dr. Jason.
Jason.
I think
Yes.
the question was about using
for
the
me,
short.
yani. It's for me.
No. The question is about using a short nail rather than a long gamma nail. It's not the shortening.
Well, I'll tell you. Ramsey, I'm sorry, I'm interfering. Carry on, please. Please, Ramsey.
Yeah.
شو كنت عم تحكي؟
عماد is talking.
عماد, I'm sorry. Please talk.
I would say that if the fracture is below the lesser trochanter, there is no point in using a short gamma nail. You use a longer one. So I was typing that in the chat anyway. So a short nail is not indicated here. A long nail should have been done. And I agree fully with Dr. Abdallah about the fact that taking out the excess bone is not excess bone, it's an unreduced fracture.
Yeah.
And if you can see the initial X-ray after the reduction, as Johnny has mentioned, it is abducted, externally rotated, and flexed, the proximal fragment. And the beauty of that is that it shows you the deforming forces at the hip. So this hip was not reduced, it was nailed in situ. And taking out the excess bone would still cause the proximal fragment to be externally rotated, which means that the distal fragment is internally rotated, and this would cause in-towing. So even if you take that out, there is a rotational malreduction of this fracture. So even if you get a beautiful X-ray, add bone graft and get healing, which I suspect not, you will still have an externally rotated proximal fragment and in towing in this patient.
But if you lock it, there's no problem, Ahmed. If you lock it in neutral position, there's no problem.
I don't think it is being locked. I don't think it is being locked in neutral position. The proximal fragment is externally rotated.
You can
do a
lock
CT
it,
scan,
of course, definitely.
Yeah, the surgeon who has already nailed this fracture in its unreduced position would not have recognized that external rotation and would have probably fixed it in internal rotation of the distal fragment, and in the patient would be in towing. I can assure you that.
Okay. Lucky, can I comment? Just one second. The comment is about using the fixation device. I will use a second generation nail in this way. I would, because you have a good portion of the proximal fragment intact. Number one. Number two, I would definitely refuse to remove any fragment. Why, Ahmed? The reason why, in the subtrochanteric, if you go into the biochemistry, where I have gone in repeatedly into the biochemistry, this is an area where you have non-union, where it's predisposed to non-union, not only due to the leverage of the fracture, it's due to we have very little blood supply. It's mainly tenderness in the area. You have the vastus lateralis, and for this reason, I will not remove any bone. I would, if anything, I might even consider bone grafting it. And this is it. I would use a second generation nail. I would lock it both proximally and distally. I won't have the problem of rotation whatsoever if I lock it in the proper position. And thank you.
Yeah.
Thanks.
Thanks so much. We can. Yes.
The last
Can I share
case.
my screen?
No, not yet.
Not yet. Excuse me.
Are there any more cases?
One case.
One case.
My screen is visible?
Yes,
Yeah.
it's okay.
Okay, this is a 35 years old male, sustained a minimal trauma, okay, and he presents this subtrochanteric fracture. 2 days after, it is treated by DHS. What do you think about, I asked the panelists, what do you think about, this fracture?
It seems like a stress fracture. I think maybe another disease like insuffisance rénale.
There are multiple diseases that give you this X-ray apparent. You have to think of Engelmann's disease. You have to think of osteopetrosis.
Osteopetrosis.
You have to think of vitamin D intoxication.
Yes.
All three can give you it. The problem with Engelmann's, it occurs in one long bone and then it disappears to go into another bone. And the problem is in osteopetrosis. The osteoblasts are not normal. You don't have the proper remodeling process of osteocytes and osteoblasts and remodeling, etc. And this is a reason why bone gathers. And when it gathers, the patient is anemic. Sorry, I talked. And don't forget about Paget's disease.
Yes, Dr. Johnny, you are right. This is a case of osteopetrosis. And as you said, there is a defect in osteoblast and accumulation of osteoblast. So this is 8 months after, and we have still non-union. And we have many difficulties. I just mentioned this case. That's for, the difficulties we had in the operation. And especially, we can recognize that increase the cortical thickness and loss of medullary canal and bone-in-bone appearance, as you said. And so I want to mention that the technique, we have the plates, of course, or the intramedullary device. Dr. Johnny, do you think that we can go for intramedullary device with loss of medullary canal?
Let me tell you, I had one such case that I went with an intramedullary device, but I was not happy enough. So what did I do at the time of operation? I got a hernial mesh, and put it around the fracture site and filled it in with autograft, mainly cancellous bone.
Yes.
Now, some say it's better to fill it in with cortical bone. Why? Because it's not resolved that easily, but that's the problem in this case. So I use cancellous bone, and believe me, the fracture united. This is a case I devised. Why? Because I was using it in limb-sparing procedures where I lacked a big gap of bone. I would get the mesh and fill it with cancellous bone, and it's rather a technique taken from Musculet. Musculet does it occasionally in infectious cases. I do it in non-infectious cases. Okay? So I will do it. Believe me, do it and try it, and then curse me. Okay?
We want to say that the recommendation that in this case, first you have to use, the slow, steady drilling, and
yes, it cracks. It breaks.
And also we have, many drill bit breakage, so you have to frequently change the drill bit, and constant cooling because of overheating of the bone.
Mazboot.
The problem I don't have,
there is another condition I'm thinking of it is malrheostosis. Malrheostosis is like a candle drip of bone, which gives it, but it doesn't give a total involvement. It gives a partial thickening of bone. You see, you have to think of this. Put a differential diagnosis. In children, you might even have to think of vitamin C deficiency. Why? Because they get hemorrhage, which is subperiosteal, and the whole bone becomes thick. You have to be careful of it. Some even include cases of Ewing sarcoma. So think of all this in the differential diagnosis. And this is what I tell our children, our residents, that you have to get adjusted to a proper differential diagnosis. This is the learning process. And thank you.
Yes, I want to say that this, a hard, brittle bone, and it's difficult to drill this.
I agree.
Bone. That's why we had this, lag screw is not really center, and it is difficult to treat this condition.
I agree with you. It's a
I
very
thought, did that fracture ever heal? Do you have any follow-up X-rays?
No. Unfortunately, we don't have the follow-up. But just for this
That's a
rare
shame.
case, the rare case of osteopetrosis.
I was consulted by Dr. Jassim on a similar case last week. I think I have the X-ray. I don't know how to put it on the phone so that everybody would see it. This
So you
patient
think it is the same case?
It's another case. I don't know if Jassim is
No, it's
in the
not the same
group
case.
and
It
can
is
put
a
it.
Syrian case.
It's a nice case. And I advised him to do this technique. I don't know whether he did it or not. You see?
Okay, Khalid, we
I
have
have the X-ray.
because
I conclude.
it's too late for Middle East people now.
Yes, in Syria
Dr.
now it's
Bouzidi,
11 o'clock.
Now it's 11 o'clock.
In
لا
Syria.
10 o'clock
Yes.
نحن عنا. نحن
في لبنان 10 o'clock
10
سوريا
o'clock بعد بأول الليل
سوريا ولبنان في 1 hour difference.
اوكي دكتور خالد زيتونة
Dr.
خلينا
Bouzidi, do you want to speak about the next session?
Yes,
Wallah, it's very interesting. Very interesting.
Just I want to thank all the attendees who was with us this night. I know it's and I know that it's too late for you, but I hope that it was interesting for all of us. And thank you so much for Arab Board, for Johnny Abdel Noor, for Ahmed Sawiris, for Isam Al-Maghrabi, to be with us for this meeting. Dr. Muhammad Bou Abdullah, Dr. Karim Bou Attour, Dr. Khalid Zitouna, who was the master of this organization and coordination of all the speakers. Thank you so much for all the attendees from all Arabic countries who was with us tonight. And I invite you to the next meeting, next Zoom, and it will be about meniscal repair techniques, and it will be on 3 February next month. In 3 weeks, we will
What is the topic, Ramzi? What is the topic?
meniscal
Meniscal repair.
Meniscus repair.
Yes.
It's my weak point.
So I will send you the link and the topic and the draft and the picture of the meeting. And I hope you will be with us for the next meeting. And thank you so much. And goodbye. Ahmed, if you want to
I wish to thank you very much for inviting us. This was a challenging session, very interesting. The interaction was excellent, and everybody has already shared. I would say I would speak for myself. I learned a lot from this session. So thank you for including us in this, and look forward to more collaboration between the Arab Board Scientific Council and the Tunisian association.
Thank you so much.
Thank you.
Could you please open your
See you later.
your camera?
Have a good night.
Selfie Zoom, please.
Open the photo.
Open your
oh yeah, okay. Open your cameras.
Thank
for
you.
for the
Thank you.
photo.
Open video.
Thank you very much.
Right, that's
See
very
you
good.
on
Yeah.
February 3rd.
Thank you, Qatar.
Yeah.
Bye-bye.
Thank you. It's
you.
brilliant.
Bye. It was
Bye.
great.
Bye.
Yeah.
Goodbye.
Thank you, everybody.